And for those joining, at the bottom of your Zoom, there is a little button called Live Transcript, and it has CC. And if you want, that's enabled, that's our closed caption. If you'd like to put that on, sometimes people find it useful. And then you can read what is also being said. I'll just give it a couple minutes. Hello, everyone. We're just giving it a couple minutes. We had a lot of people register, so hopefully they're able to access through Zoom okay. I see a lot of friends that are joining from core group. It's nice when people have the photos also. You can please introduce yourself in the chat box as we get started. Can tell us where you're zooming in from. We're just going to give it another minute because, as I mentioned, there was quite a few that have registered, and I just want to make sure they're not having access issues. I'm excited to see how many countries we can get today. I'm seeing Uganda, welcome. India, Geneva, good to see you, Tom. Kenya, karibu sana. So Pakistan, excellent. Some more Nairobi and Ethiopia, welcome. Nizam, welcome from Bangladesh. Paris, welcome. From Laos, but Paris. Mozambique. Yeah, it's quite the diversity of countries. That's great. Abuja, welcome. All right. Well, as we continue to let people in from Zambia, Uganda, India, Bangladesh, and onwards, continue to introduce yourself in the chat box. And as I mentioned, there is a button called Live Transcript at the bottom of your Zoom. If you want, you can put that. That will enable closed captions. My name is Lisa Hilme. Greetings to all. I'm the Executive Director of Core Group based in Washington, D.C. And Core Group is celebrating 25 years this year of collaboration, of learning around the globe. And we have more than 15,000 in our International Community Health Network, multiple members from Africa, Asia, the US, and other countries. and partners that are joining us through our projects in community health and well-being. And I'm pleased to welcome you today to this webinar. We will focus on success stories of integration of immunization services to reach zero-dose children and other health areas. We know that the COVID-19 pandemic, it's fueled incredible backslides in vaccinations, more so than the past 3 decades. And I'm sure many of you have seen the World Health Organization and UNICEF report, the new data that shows that the global vaccination coverage continues to decline in 2021, with 25 million infants that have missed out on life-saving vaccines. And so we need to act now to change this and to get these children immunized. So today is especially important. We're going to hear how organizations have reached zero-dose children or children that have not received a single dose of DTP-containing vaccine, especially in hard-to-reach areas. And I'm excited that Core Group can bring us all together so that we can learn more. We know that there is a lot of discussion about integration of the immunization services, and there are some challenges with that. However, it can be done. And we are going to learn today about some of those success stories. And it will be important to take these lessons and to implement these changes back into our programs and to advocate for them, as well as to continue to advocate for the children in the hardest to reach areas and communities that need this immunization. So I know I'm really hoping that folks, we have quite a few hundreds actually that have registered. And even though it's a busy time, I'd like to thank you for joining us today, because I think all of your lessons, your questions, use the chat box, introduce yourself. They're going to be very important for all of us to learn. So I'm pleased now to turn over to Ms. Naomi Senda, who is Core Group's Communication and Knowledge Manager, zooming in from Nairobi. And she will lead the webinar and introduce our wonderful speakers today. So Naomi, over to you. Thank you.
Thank you so much, Lisa, for the introduction and setting the stage for this webinar. True to your word, it is quite an important conversation that we're having today. And I'll go right ahead to introduce our panelists for the day. The first panelist I'll introduce is Dr. Om Prasad, who is representing WaterAid today. And Dr. Om is a public health expert and behavior change scientist with more than 22 years of experience in work and research in WASH, health, behavior change, child immunization, food safety, disease surveillance, and HIV programming. Thank you so much, Dr. Om, and we are looking forward to hear what you have for us today. Our next panelist joining us from Cameroon is a physician and public health expert. That is Dr. Clarence Mbanga, who's representing the Clinton Health Access Initiative today. And Dr. Mbanga has experience working to help improve the health of people in rural and marginalized areas. He has worked as a primary caregiver across rural areas in Cameroon and has also worked to eliminate preventable maternal and childhood deaths. Our third panelist for this conversation is Dr. Preeta Biswas, who is a senior technical advisor supporting contraception, maternal, newborn, and child health technical areas at Pathfinder International. She's an obstetrician and gynecologist and healthcare management expert and has intensive experience in diverse areas of healthcare, such as clinical governance, capacity building, service delivery, and health systems strengthening. Our last panelist that I'll introduce today is Dr. Amalin Vongsinthi, and I'll give her a special chance to give a very brief introduction of herself now. Dr. Amalin.
Yep. Can you see me? Can you hear me?
Yes,
now?
we can.
Okay. Good afternoon, everyone. My name is Dr. Amalin. I am a health director. I'm working with Save the Children Lao, but now I'm swimming in Paris for my vacation. So I'm working with Save the Children for almost 3 years, and my focusing is for the maternal and child health newborn and reproductive health, and adolescent health in Laos for almost 10 years. So thank you for SCI Lao and to give me this opportunity to come to talk with all of you and exchange the knowledge with everyone. Nice to meet you all.
Thank you so much, Dr. Amalin, for introducing yourself. So now I also take this opportunity to specially welcome every participant in this room and in this discussion today, joining us from literally all corners of the world. We are happy to have you here, to host you here in this discussion. We encourage you to give your comments or questions to the panelists in the chat box. And at the end of the presentations, we'll be addressing the questions in a question and answer session with a panelist. We'll begin with our first presentation of the day, which is a presentation from Pathfinder International by Dr. Preetha Biswas, where they'll be giving their success story on the integration of immunization with sexual and reproductive health services. Dr. Preetha Biswas, you're welcome to take the stage.
Thank you, Naomi. Good morning, good afternoon, and good evening to everyone. And I'm really pleased to be part of this panel today to share experiences from Pathfinder Tanzania and Burundi on how they have integrated immunization with other SRH services. I'd like to request Naomi and or Julia to share the slides if possible.
Yes, we're sharing it. You could proceed.
Can you share the slide deck? I mean, either you or Julia, if that's possible.
There, can you see it?
Yes, thank you, Naomi. I think it, yes. So next slide, please. I'll start with Pathfinder's experience from Tanzania. So in Tanzania, our experience is from the Mamuzi Yako Kesho Yako project. This is a project that is funded by the Bergstrom Foundation, and this is focusing on community-based family planning services. What the project does, it offers family planning services to postpartum women using the immunization window. And as all of you know, that this is one of the promising high-impact practices in family planning. The project, if you look at the diagram, and this is a little sort of confusing, but I'm just going to explain it in a little more detail. So the project works with the public sector at the community level. So it works with the regional and the council health management teams. And this is what it does. It tries to increase access to family planning and contraceptive services to 60 rural and underserved and very remote communities or villages. And 30 of them are in the Shinyanga DC region and another 30 in the Kahama DC region. And the two approaches that the project uses are a facility-backed mobile outreach approach and also using community health workers. Now, all of these mobile outreach events are providing integrated services. So all of them provide integrated family planning and immunization services. In terms of sensitizing the community, the project engages the community leaders and community health workers prior to these events in order to generate awareness and sensitize the community and also create demand creation so that they have maximum participation of clients at these events. The project also works to build the capacity of about 120 community health workers from these 60 villages, about 2 per village. And what they do is they increase demand for family planning services. They also distribute short-acting methods like condoms and pills. And they refer clients for LARC and permanent methods to these outreach events that are scheduled. The mobile outreach events integrate immunization services, as I mentioned, as an important window to reach postpartum women with high unmet need in these villages. And in a preliminary study, which has not been published yet, this model was found to be acceptable to both providers as well as the clients. The clients found that it lowers their transportation cost. It saves them time because they don't have to come twice for 2 different services. And providers felt that it reduced the burden on the health system. One of the challenges the project perceived was that during these events, women come for a number of services. So they come for immunization of their children, they come for growth monitoring of their children, and they also come for their own SRH and especially family planning needs. But the data on integration is not very robust because the project indicators do not sort of mandate a disaggregation of data by reason of attendance, that is whether the women have come for immunization of their children or whether they've come for an SRH service. Next slide, please. I'll now briefly talk about our experience from Burundi, which is very similar. So in Burundi, Pathfinder is implementing the USAID-funded Tubuteho project, which essentially means let's take care of them. This is again integrated health project, which covers 6 provinces, 16 health districts, and 390 health facilities, and has 5 main components: family planning, maternal newborn child health, malaria, gender-based violence, and nutrition. In this project, Pathfinder Burundi is integrating immunization and SRH in 2 different ways. One is at the facility level and the other is at the community level. So at the facility level, immunization services being very popular because immunization coverage is very high in Burundi. The routine immunization services are being used as an entry point to integrate SRH services in 305 out of the 390 project-supported facilities. So women who come for their child's immunization are provided group counseling and information on family planning. And this is followed by individual counseling for those who are interested in taking up a family planning method. And then the method of choice is either provided at the facility or the client is given an appropriate referral. At the community level, they have used mobile clinics as an entry point for immunization and SRH integration. So these mobile clinics were initially deployed during periods of peak malaria incidents in the hardest hit areas of the northern and southern provinces, and they were used for malaria services and malaria control activities. However, the scope of 6 of these clinics, 3 each in the 2 health districts of Matana and Bururi, were recently expanded to provide integrated services at community level. So in addition to malaria screening and treatment, these clinics are also now providing postnatal care, immunization services, they're covering immunization dropouts, and also providing family planning services. And they are doing this with prior community mobilization with the help of community health workers as well as community leaders. Some of the challenges or lessons learned from the Burundi project were that to provide individual family planning counseling is a big challenge during these integrated services. And also the absence of husbands during immunization services, because it's usually the mother or the caregiver that comes with the child for immunization. This does affect family planning uptake because women are not the decision makers, and it's the husband or the spouse who's the decision maker for their wife's use of contraception. And the third lesson, again, was very similar to Tanzania, is about not having enough robust data related to integration. This is not collected or reported. So this is in brief our experiences from Burundi and Tanzania, but happy to sort of answer to questions later on any of these projects. Over to you, Naomi.
Thank you so much, Dr. Pritha, for sharing the experiences from Tanzania on the mobile outreach clinics, and that from Burundi on how the mobile clinics are the ones that were specifically for malaria, now integrating antenatal care and immunization services, among others, to the clients. A question now. What direction do you think the immunization community needs to move towards to reach communities that need the services the most?
So as you can see that both our programs were, focused on communities most in need. So I think in terms of what the immunization community needs to focus on, I think one is addressing vaccine hesitancy. This is, I think, a universal problem in most settings. And I think this is further aggravated by misinformation spread by social media. So I think working with key stakeholders to develop a strategy to combat misinformation is very important. I think another important area is basically, and I think this is critical, is to actually engage the communities that are being given these services or that are users of these services. So essentially by learning about what their thoughts are and what their needs are on quality vaccination services, and then actually actively engaging them or involving them in designing immunization, communication, interventions and products, and also, increasing their awareness on the need for quality vaccination or quality immunization services. So what are the benefits of that? Another area I would, I think, like to talk about is, working with civil society and grassroots organizations in these, who are working in these hard to reach communities. They could be women's groups, formal or informal. They could be youth networks, girls networks, because they are the ones who work with these communities, and they can, help to sort of advocate for them and help to amplify their voices to the decision makers. I think some other areas that I would like to sort of just highlight are kind of, making sure that you have a robust cold chain. I think that's critical. And also, I think strengthening the frontline workforce by sort of strengthening their capacity to provide, quality immunization services. So I think these are some of the areas that the immunization community needs to focus on.
Mm-hmm. Thank you for those responses. And one thing I note from the response that you've given is the importance of involving the communities in decision making on their needs and the services that could be used, that could be integrated. Our next question is, what would your recommendations be to donors and policymakers and even civil society to ensure that immunization programs are gender transformative?
I think this is a very critical area, and some of the things that come to mind are, one is, as I talked about earlier, the need for robust data. So normally immunization program data does not collect disaggregated data, for example, coverage by sex, and also age, location of users, ethnicity, education, because this is really key to identify and respond to gender inequities and design gender responsive programs and policies. It's also important to see that the communication that's being used for immunization programming is, whether it's interpersonal communication or using media, is one that promotes gender equality. I think another very important area is, engaging men. As I mentioned earlier, one of the challenges that we saw in Burundi was that, men were not there with women who came in with their children for immunization, and therefore women were not able to sort of use family planning services. But in the same way, I think it's very important to engage men for gender transformative immunization programming, because, whether it's through men's associations or groups like traditional cultural religious leaders, because, as I said, immunization programs mostly target women, with the information and messaging, and they ignore this critical influence that men have as decision makers for their spouses. And in a lot of the settings that we work in, gender inequality and patriarchal norms, they actually allow men to control women's access to time. So women are too busy doing their household work to actually access immunization services. Women's access to information, to finances, to transportation and other resources to access healthcare services, including immunization, is largely dependent on men. So this is very important, to ensure gender transformative immunization programming, engaging men. And I think it's also important in another way, because if you target just women, you also miss out on the benefits of involving men as caregivers. So I think engaging men is key. I think also two other things that I would just quickly want to highlight is basically, if you, I think it's important to engage with initiatives that, build women's capability and really capacity and agency and self-efficacy, because, for example, skills building programs and economic empowerment programs. And finally, I think we must not forget the health workforce, because we know that the frontline workers that provide immunization services, a lot of them are women, and they're affected by gender inequality in terms of, unequal remuneration, not having leadership positions, unequal promotions, discrimination, and sexual harassment in the workplace. And this affects their physical and mental health, and also their ability to provide or deliver quality immunization services. So I think we need to recognize the work that they do. We need to elevate their status in the health system, and we need to support them, and we need to pay them for the work that they do. Okay. And also, I think in terms of security threats, so and also ensure that they don't face security threats when they go to their place of work. So these are some things that I would like to highlight.
Thank you so much for your comprehensive responses, and we're getting some reactions to the suggestions, the proposals in the chat box. Just to encourage all our participants to give your comments, your questions in the chat box, and we'll address them at the end of the presentations. At this moment, I'd like to introduce our next panelist of the day, who's Dr. Om Prasad Gautam from WaterAid, and he'll be speaking about the integration of WASH behavior change into immunization programming. Dr. Om, the floor is yours now.
Thank you very much, Naomi. Hopefully, can you hear me okay and also see the slides? Or you're on mute? Can you confirm you can hear me okay and see the slides?
Yes, we can.
Thank you very much. Great. First of all, thank you very much for inviting me and WaterAid to present our experience on integrating hygiene behavior change programming into immunization program. WaterAid is an international charity. We work in 37 countries across Asia, Africa, and Latin America. So for today, I'll be specifically focusing on our experience on integrating WASH intervention, primarily behavior change intervention into public health programming. So first of all, I just would like to highlight what do we mean by hygiene integration into immunization. So if you have a young children, either guardian or a mother with a young children has to visit immunization clinic at least 5 to 7 times within a year or two. When they visit the immunization clinic, currently in many countries, they go and vaccinate their children. There is no provision of extra hygiene behavior change session. So what I mean by integrating hygiene is exposing them with 30 to 45 minutes hygiene session before they actually vaccinate the kids. Second, that is through routine immunization. Second, when guardians or anyone visiting the clinic for any supplementary campaigns, including COVID or other vaccinations. So idea then, how could we expose them with the hygiene intervention? So it could be light, it could be just one-off or two-off, depending on the supplementary immunization clinic. Why hygiene integration? Because we really see the integration can bring synergy, particularly to improve the efficacy of the services and also for the service provider. We see improved immunization coverage and reduce dropout. But at the same time, we see integration can improve behavior for the benefits, wider benefits from the routine immunization. But at the same time, hygiene integration with supplementary vaccines, because there is a tendency to see that all vaccines is seen as a silver bullet. But it's not silver bullet, because vaccine efficacy, as we know that not all the vaccines are 100% efficacious, and preventive behaviors is still relevant. Vaccine rollout timing offers a great opportunity to integrate hygiene, but at the same time is a real-time opportunity to reinforce behavior, and good hygiene behaviors are still essential for enteric vaccines to be enteric disease to be prevented. Today, what I'm going to highlight few inspirational examples led by government, but then supported by WaterAid. The first one is the Ministry of Health in Nepal learns an integrating hygiene into immunization program is a pilot project in 2016, and subsequently in 2020, it has been scaled at nationwide fashion. And we have also integrated hygiene into COVID vaccination program in South Africa, in Mozambique, in Nepal. But because we only have limited timing, I would focus on the first one, integrating hygiene into vaccination program from pilot to scale. How could we implement a pilot, and that has been led to the scale implementation in a nationwide fashion. So this program, particularly integrating hygiene into routine immunization program, was piloted initially in 4 districts in Nepal with an aim to improve behavior, strengthen immunization system, and see whether the integration can be feasible and whether it has been considered as a missed opportunity. So the initial pilot project implemented for 2 years, and subsequently it was then retained for 4 years, and then subsequently later in 2020 it has been nationwide fashion. So we have used a behavior-centered design approach to implement this. The behavior-centered design approach includes 5 steps. So initially, we have done the scoping study just to understand whether it is feasible to integrate. Subsequently, we have done the formative research in 2014 to understand the behavioral determinants, understanding the different touch points to deliver and integrate. And then in 2014-15, we have designed the intervention package, more emotional and more attractive, engaging behavior change intervention package. And in 2015 and 16, we have piloted in 4 districts. And then evaluated the program in 2016 and 15 as a baseline, and also 17 as an inline. So to compare the results. So the program was delivered through existing immunization program, initially by female community health volunteers and health workers, and subsequently any scale we are implementing through health workers. We have focused 5 behaviors, including exclusive breastfeeding, hand washing with soap, water treatment, clean use of water, and food hygiene. The idea that anyone visiting the immunization clinic for vaccinating their children will be exposed with 45 minutes hygiene session in pilot, and subsequently at the scale up, we have 30-minute session. We have designed very Kiriti package. The Kiriti package has its own branding. We call them Ideal Family Campaign. It has used the emotional drivers. And the campaign has lots of exciting activities, games, competitions, demonstrations, visual cues, and nudges, behavioral nudges to reinforce the behavior. In pilot program, we have exposed 35,000 mothers with the young children, and subsequently that has been retained for over 4 years. In 2020, when we implement at a scale, we actually raised 650,000. We are implementing in all 77 districts throughout the Nepal, and we are reaching 650,000 young guardian with a young child. Let me show you a video that will explain you how these sessions are being implemented. Yeah.
This is Pramila and her son Mani. Pramila has been taking Mani to the health clinic in her local village in Nepal for vaccinations. At the same time, she's been learning about the importance of good hygiene. She washes her hands before feeding Mani and makes sure she properly reheats food. In Nepal, more than half of the population do not have access to a decent toilet.
That was in 2015.
More than
Now
1,200
50.
children died from diarrhea in 2015. But things are beginning to change. The government of Nepal is integrating hygiene promotion into its routine immunization program. Female community health volunteers are empowering new parents to use good hygiene practices. This means the government can accelerate improvements in child health, reduce healthcare costs, and strengthen their economy for the future. Through an integrated approach, we can create a positive cycle for children like Mani so they can grow up strong and healthy and fulfill their potential. Act now. Coordinate, integrate, invest.
Thank you. So what was the effect of the intervention? So intervention was initially implemented as a pilot. So it has improved behavior from composite behavior, the 5 behaviors from 2% to 53%. It has also has an effect on improving the immunization coverage, primarily on the measles vaccination coverage from 70 to 91%. As a result of this effectiveness of this intervention as a proof of concept, government has retained this program over a period of 4 years from 2015 to 2019. And in 2020, the integration program learns nationwide fashion together with the routine, through the routine immunization, synchronizing with the rotavirus vaccine, because at that time the country was rolling out the rotavirus vaccines of rota linked with the hygiene behavior change. So it has been then rolled out throughout the nation in 2020. So my final slide on this. So what has been the strength and lesson learned from this initiative from pilot to scale? So the key lessons here: immunization offers a unique opportunity for integration. It offers a mutual benefits. If we are integrating with the right intervention package, it offers a mutual benefits for behavior change as well as for improving the immunization coverage. So integration actually strengthens the system. So it improves the behavior and it also improves immunization coverage, reduce dropout and vaccine wastage. We have seen lots of evidence on this. Of course, there is an additional cost for integration, but initially it was costed as a pilot on $4 per person. And when we are transiting from pilot to the transitional phase, it was only costing $4. And subsequently, when you're scaling up nationwide, it is only costing at around 1.75. So the nationwide costing is quite heavily reduced. So what has been the strength for success? So this program was fully owned by government, implemented by government, and supported by technical partners like WaterAid. It has been transited from pilot to the scale as a proof of concept. The proof of concept package which was tested was scale. So therefore, there is a confidence that
wrapping up. Time.
Oh yes, yeah. I'll be finishing up this, and then this was implemented through a sustained routine mechanism because it's implemented by the government health staff. Focus on a strengthening system and use behavior-centric approach. And intervention has high reach of coverage and compliance and a strong supervision from the government. And it has an emotional, attractive, engaging package so that when mothers attend the immunization clinic, the huge inspiration for them to also attend hygiene session to change the behavior. So yes, those were the just very quite reflect. I mean, the light reflection from the heavy program implemented since 2015 to 2020. Huge thanks to the government of Nepal and other supporting partners, including USAID and WaterAid for this. Thank you. Over.
Thank you so much for that comprehensive presentation and for the interesting animated video. One question that we have for you is, what has been the biggest factor of success and the strategy that other actors could use to reach zero-dose children? If you could briefly give us a response to that.
Sure. I think the biggest success factors are 3. One, if we are thinking something implementing at a scale and really sustaining, so we should be definitely working with the government system, building the government capacity, and involving government since the beginning, so that at least there is a ownership, there is a competency and capacity, and when implementing it, there is a confidence in the system. That is one. Second, when you are testing something as an integration modality, we should not ruin the existing success of those programs. For example, immunization is one of the successful programs in many countries. There is a tendency that integration might dilute the existing success of those programs. So therefore, we need to be very conscious what we are integrating it. So therefore, during integration, we are very conscious that we will be only implementing and integrating proof of concept intervention if there is a mutual benefit. Therefore, we have done the piloting. Pilot was successful. The proof of concept package has worked in terms of changing the behavior and improving the immunization coverage. So therefore, the learning here is it is important for us to be more evidence-based and test as a proof of concept, then only integrate. Otherwise, this will have a multiple effect. The third one is any integration program should strengthen the system, because if we are implementing as a pilot initiative, that's not going to be successful. That's not what we want, right? So the system is quite important. System meaning how could we improve the existing immunization system in terms of capacity, have a mutual benefits for both the program. Can we also have use the routine mechanism of monitoring and also strengthen that system so that any integrated program should actually build the system rather than implementing in a vertical modality. If there is a mutual benefits, if there is a system strengthening elements part of it, then the integration is possible and feasible, and it has a mutual benefits for both the program. Over. Naomi, you are on mute if you are talking. Yes, please, come on.
Thank you so much, Dr. Om. We'll move to our next panelist, Dr. Amalin Bongsimpi from Save the Children, who'll be talking to us about the success story of the maternal and child health integration clinics in Laos. Dr. Amalin, you're welcome to take the stage.
Yep. Sorry, can all of you see my screen now? Yes. Okay.
Yes, we can.
Yeah. Good morning, good afternoon, and good evening, everyone. My name is Dr. Amalin. I am a health director. I'm working with Save the Children Laos. I'm based in the north of Laos. So first of all, I have to say thank you for our SCI Laos office that they give me the opportunity to present and to sharing the experience and our lesson learned with all of you. Yeah. The next one I would like to present about the RMNCAH, the integrated outreach with COVID vaccination. So in Laos, we have been supporting the mobile clinic that provide the comprehensive RMNCAS service and care for the elderly and for disabled since before. So start from the beginning of 2021, we implemented in the north of Laos. We integrate the RMNCAH activity or mobile clinic with the COVID vaccination. So we start in the beginning of 2021, and we following the COVID vaccination rollout by the provincial health department and our district health office. So our SCI team will be the main partner for them. The mobile clinic aim to increase to access to the health in the remote area, because when we decide to conduct the integrate outreach activity, we decide to do it at the remote area that is very far from the city or from the health facility. So the most focusing is for the ethnic group and especially for the women and the children on that area. So we still have the list below. You can see here that what we are doing during this activity. So During this event, it will be including with the health education at night time, because we spend almost 1.5 days to conduct the event per village. When we traveling at the evening time and at night time, our team will do, our team, I mean, is the government team, and that they will conduct the health education or health counseling at night time, because the villager, they will not stay longer in the day. They have to go to the field to for their life. So at night time, we will use that opportunity to stay in the village and provide the health information. So, and in the morning, we will conduct the health checkup for everyone, for children, elderly, women, everyone. And we also do the cycle monitoring. The cycle monitoring will be including the hygiene or sanitation session as well. Example, the washing hand and cleansing the village, something like that. And another thing is, when we conduct this activity, we will have the ANC, PNC, and family planning for everyone. Everyone, that's mean for adolescent, from the women with reproductive health age, yeah. And another activity is about the vaccination. Vaccination is will be including the routine vaccination, and as we know right now, we have the COVID vaccine. So during one event, we will including many activity together. So that's why we call integrate in Lao. Yeah. So the next one is with our let's learn about the COVID response, or during the COVID pandemic. What is yeah. So we learn we thought that all routine activity integrate with the COVID-19 response. So because or any outbreak, not only for COVID, but if they have any pandemic or any outbreak, so we should including so integrate the work together or respond together, in order to ensure that in the the last to combat the pandemic, the target population that we serve do not miss out of the essential primary healthcare service. Because in Lao, we focusing on our program, our portfolio is for primary healthcare. So another lesson we learn is that in cooperating in traditional leader and influencer, when we conduct the advocacy for vaccination abstract, is important. Yeah. So the next one is about the picture for our activity. You will see here, we not only the mobile vaccination that we integrate with the COVID vaccine, so but we still have our SBC activity, so we also include or integrate with the COVID response as well. You will see here is our village health volunteer. When they go to do the household visit, when we do the SBC event, yeah, we will have the information or the material for them, the IEC material for them to provide the health information or the counseling for the people in the village. Yeah, this is the example for the vaccination for everyone. So this is the elderly and including the disabled person. Sorry. Yeah. Same with this one, we will do the ANC in the house, because during the pandemic in Laos, it's very hard to reach all our all of our target audience. They did not go to the health center, they did not go to the district hospital because they are worried a lot. So this will be in effect for for the health service that if we did not integrate our work with the COVID response. These two. Yeah, you will see here we do the goal monitoring for the student under 5. Yeah, and it's really hard because the villager they try to go out to to work, but so the medical doctor try to do everything to reach them, to catch them. Sorry. And this also is our activity is mobile vaccination at school, and you will see here is the elderly at the temple. Yeah, there is some data that we can see and prove that when we integrate all our activity with the COVID response, it will be better to make it to make down to help us to achieve our target. You will see here the number the mortality of the maternal and child health. An example is in the north of Laos. For here is not our target district. No, we see it's not. I will go first. Yep. Example here, when we do, we can see the example from here that the coverage of the SPA in the north of Laos is still acceptable or high in our target district. Yeah. This is the coverage of the people who received the first dose and the second dose in the north of Laos. Yeah. Sorry, the data maybe it's not really updated because I took that in many months already. Yeah, I would like to say ขอบใจหลายๆ is a Lao word that this means thank you. If you have any question, please feel free to.
Thank you so much, Dr. Amalin, for your presentation. And just to pick on one comment by Tom Davis in the chat box, where he notes that so many children missed out on the vaccination during the pandemic, and integrating those into COVID-19 immunization is quite a good example of how we could do the integration. So a quick question to you. How can we shift and make progress given the decline in coverage of immunization during the COVID-19 pandemic? What ideas do you have for us to make progress here?
Thank you for your question. As I mentioned in the beginning, we try to adapt, we try to do the new thing, or we call advocacy in each level. That means during the pandemic in Laos, it's really hard. That means everyone cannot move. We have to stay in the house. So on that time, many of our activities have to be stopped. We cannot learning everything. So we talk with the Ministry of Health and to find a solution, and the provincial health department that. So whatever the pandemic is still going on, but we have to still concern about the abstract of the RMNCS service. So we try to integrate. That means all activity. Example that I saw to all of you, that we will have the SPC activity to make our activity going on. So we try to have some topic or some activity of the COVID response, because in that time our government that is very strict that okay, only the COVID task force that can move, can go out something. So but we try to do advocacy with the Ministry of Health and by all stakeholders that. So we have to integrate this work together. That's why I saw it. Maybe I did not bring very good data, but example like this one, the coverage of the skilled birth attendant at our target district, because here is the target district, is still acceptable and not very not decreased a lot. during the COVID pandemic. Yeah.
Thank you so much, Dr. Amalin, for the story, the case example that you've given us, and even for providing this data. Just to note to our participants that yes, you will be getting copies of these presentations and even the resources that are being shared in the chat box later, together with a recording of this webinar. So to welcome our last panelist of the day, this is Dr. Clarence Mbanga, who will be speaking on the integration of immunization program with MNCH services to strengthen the birth dose platform in Cameroon. Dr. Clarence, you're welcome.
Thank you very much. It is a pleasure to be here. Let me just quickly share my screen. Can you all see my screen?
Yes, we can.
Okay, great. So, yes, like you already mentioned, I'm Dr. Clarence Banga with the Clinton Health Access Initiative. So CHAI is a non-governmental organization that has been, over the past 20 years, working with both governments and private bodies in low and middle income countries to create and sustain quality health systems in the effort of saving lives and reducing the burden of disease in those countries. So for the presentation of today, I'll be focusing essentially on the work that CHAI has done in Cameroon in regards to integrating immunization with maternal and child health services in the effort of strengthening the birth dose platform in Cameroon. So as a brief story, Cameroon is among the countries in Africa with a really high prevalence of hepatitis B virus infection amongst pregnant women. So the prevalence is estimated at more than 8%. And as a result, there's a high risk of mother-to-child transmission of the virus. For those reasons, introducing the birth dose of the hepatitis B vaccine has been a key priority for the Cameroon government, as outlined in several of its national strategies. So the big challenge here is the fact that the hepatitis B birth dose vaccine is most effective when it is given within 24 hours of birth. And an initial assessment, a diagnostic assessment that was done by CHAI in 2019, discovered that currently recommended birth dose vaccines, that's the first dose of the oral polio vaccine and BCG, are given within 24 hours of birth in less than 10% of Cameroonian newborn children within health facilities, showing the tremendous amount of work that had to be done for the introduction of a vaccine such as the hepatitis B birth dose vaccine. So with this in mind, CHAI, alongside the EPI, designed a 12-week pilot that was meant to test the feasibility of immunizing newborns with these current birth dose vaccines, notably BCG and OPV0, within 24 hours of birth by integrating immunization into maternal and child health services, all in anticipation for the introduction of the hepatitis B birth dose vaccine. So specifically, what the pilot sought to achieve was to deliver these birth dose vaccines through maternity and immediate newborn care services, and thereafter measure the change in proportion of newborns that will be receiving the birth dose vaccines within 24 hours of birth, as will be the case when the hepatitis B birth dose vaccine is introduced, and follow up with assessing the operational feasibility and acceptability of these interventions, and also describe any facilitating factors and barriers that could influence this integration. So basically what happened is a series of interventions were tested in these 13 health facilities across the 3 regions. And these interventions essentially tried to address challenges that were identified during the assessment in the previous assessment in 2019. So in essence, what was done during the pilot was to provide refresher courses to healthcare workers in selected facilities on OPV and BCG vaccination, including safety, contraindications, and addressing hesitancy around opening multi-dose vaccine vials. Alongside each health facility detailed, alongside each health facility detailed and tailored work schedules were developed to make sure that these maternities and newborn care services have 24/7 access to vaccine storage options, including after hours and during the weekends. Roles and responsibilities with respect to the administration of birth dose vaccines were clearly defined for all the different health workers in the facilities. And then facility healthcare workers were then trained on these specific workflows and on how to fit in birth dose administration into their services. And lastly, we developed a data collection tool to supplement existing tools, notably the birth and immunization registers, and to ensure that vaccination was properly recorded within the different pilot facilities. So fast forward to the end of the pilot, and we noticed that there was a considerable increase in the proportion of children that were receiving these vaccines within 24 hours of birth, be it for OPV, be it for BCG. As you can see from the graphs, we had absolute increase of about 46 to 45% in the proportion of children that were receiving the vaccines at birth, be it for those born within the facility, and even for children that were born out of facility, there was a significant proportion of them that were getting the vaccine within 24 hours of birth, as will be needed when the hepatitis B birth dose vaccine is introduced. And even looking at the healthcare worker knowledge perspective, with respect to administering these vaccines to clinically stable low birth weight children, there was a considerable increase as well in that direction. So in summary, the key success factors that we had, the key success factors that contributed to the results you can all see from the pilot was the fact that vaccines were not only available but accessible to maternal and childcare units and services, something which was not the case before. There was intensive caregiver sensitization and incentivization prior and during the pilot. There was a considerable degree of proactiveness from health facility administrators to mobilize their staff to actually make sure that children are vaccinated with these vaccines within 24 hours following birth. However, if you flip the other side of the coin, we had some challenges as well. And that essentially revolved around increased workload as complained by maternity staff, given that they had to do something which they were not doing before. And there were also considerable concerns about wastage and stockouts, given that vaccines such as the BCG that comes in multi-dose vials, healthcare workers were given the permission to open those vials, even if it's for 1 or 2 children, in as much as it helps to achieve the objective of vaccinating the child within the 24 hours that follows his or her birth. And lastly, there was also that difficulty of collaboration between the EPI and the maternity staff, mostly at the beginning of the pilot. But as time went through and a lot of advocacy and communication ensured between the two units, that was sorted out. So in conclusion, what we were able to get from our pilot was the fact that if a facility designed integration of immunization and maternal and child health services is implemented, it would considerably improve the timeliness of administration of birth dose vaccines, particularly the administration of vaccines within 24 hours of birth. And this integration is possible across all the different categories of health facilities in the country, be it public or private, and all across different settings, be it rural, be it public. And of course, for sustainability, it is critical to address, core challenges that we identified, such as the wastage rates and stockouts, and also vaccine hesitancy, building capacity of maternal and newborn care staff to actually administer the vaccine, and also looking for sustainable ways to motivate staff to take on this quote unquote extra work, which is to administer vaccines alongside caring and delivering newborns and caring for them. So that was a little package we had from our end. Over.
Thank you so much for the comprehensive presentation. And we have one comment from a participant, that's Abdi Jamal, who says that he reaching every child with the BCG coverage is awesome. And a question from Abdul Gayur has quite a few questions, but I'll just pick one, where he's asking if you could elaborate on the operational aspect. And did you place vaccinators in delivery rooms or trained midwives to vaccinate the newborns? And another question from Bianche, who asks for if you could let us know what specific maternal and child health services were integrated.
Could you please come again with your question? I had some issues with my network. I got locked out for it.
From Abdul Gayur, who's asking for elaboration on the operational aspects, and asks, did you place vaccinator in delivery rooms or trained midwives to vaccinate newborns?
Oh. So in effect, we trained the midwives or any other personnel that was involved in that worked in maternity units or child sense around human resource and staffing in facilities. So placing vaccinators in been quite an uphill task.
Sorry, we're struggling to hear you. I think that was a connectivity issue. Maybe you could turn the camera off just in case it's a bandwidth issue.
Okay, can you hear me now?
Much better.
Okay. Yes. So I was answering the question by saying that we actually had to train and capacitate the midwives to administer the vaccine, given that there are a lot of concerns around, staffing and availability of human resource to actually dispatch vaccinators in these maternities and childcare units. Over.
Okay. And probably a final question for you from the floor in the interest of time. Could you please let us know what specific maternal and child health services were integrated?
Okay, thank you for that. So in effect, what we integrated vaccination into was the immediate care given to newborns after birth. That's essentially that immediate package of care that's given to newborn babies immediately after birth. So once a baby is delivered and the umbilical cord is cut and the baby is cleaned, and maybe the shot of vitamin K given on the right eye immediately, the OPV is given orally, and BCG is given.
Okay. Great, thank you. And I can see Tosin, who's also from Clinton Health Access Initiative, is also providing an answer to Bianchi's question. So that brings us to the end of the presentations and the Q&A session with our panelists. Thank you so much for your participation. Just to share again is that we'll be sharing the resources with you and a recording of this webinar for your reference. And I now hand it over to Lisa Hilmy, the Executive Director of Core Group, to wrap this session up. Thank you.
Yeah, thank you so much. I think it's amazing how we have so many people from around the world, and the very specific examples we heard today and excellent questions. will really give us food for thought on reaching zero-dose children and integration of services. So thank you very much. Thank you so much, Naomi and Julia from Core Group, doing an amazing job. And thank you so much to our presenters taking your time. We will distribute this, and we have a special animation video for you also that was developed on how to reach zero-dose children. So we'll be sharing that. Thank you very much. I hope that you all have a lovely rest of the week.
Thanks, everyone.
Thank you.
Thank you. It was a pleasure being here. Nice day.
Thank you all. Bye.
Thank you.
Thank you, everybody.
Thank you,
Bye.
Lisa. Thanks
Wow.
for
Thank you,
thanks to all
everyone.
the participants for being here.
Thank you.
So many friends are on. It's so nice.
Yeah. It was